You're watching Managing the Patient with ADHD, helping your registrar deliver best practice care. Produced by GP Supervisors Australia and presented by Dr. Hugh Morgan. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders past, present, future and their families.
I'm looking forward to talking to you all about ADHD, something which I'm very passionate about. So just in terms of the outcomes, what I'm planning to do is to just walk through the epidemiology, the clinical features, the diagnosis and management of ADHD in young people and adults, and to look at how you can support your registrar to recognise patients with ADHD and to manage them, and to understand how you can work as a co-prescriber of stimulant medication with a psychiatrist for yourselves and also for your registrars. This is a classic painting in an art gallery in Edinburgh when I was there for a conference. And I thought this was striking. It's a scene in a schoolroom set in about 1670. And you can see a boy on a table and it's all looking very chaotic. And what is interesting is the description. So Jarnstein, this shows how this painting demonstrates the evils of inattentiveness in a school without discipline. And it's quite interesting, the moral that's emphasised in two features in the painting is a print of the great scholar Erasmus, which has been discarded onto the floor, and a child who offers a pair of spectacles to the owl near the lantern, supposedly illustrating the Dutch proverb, "What use are glasses or light if the owl does not want to see?" And the reason I think this is so poignant is that for a lot of people with ADHD, there's tremendous stigma about the condition, and it can be, I think, trivialized by people. So this is an important issue, and a lot of people are a bit unclear whether adult ADHD is separate to ADHD in childhood. And there's been quite a lot published actually in the literature about this. There's been a lot of speculation about whether it is separate, but I think more and more what has been found is that studies where it had been thought that ADHD may arrive de novo in adulthood, when they look back, in fact, ADHD is generally picked up in childhood. So the thing that is important in terms of assessment and diagnosis is that ADHD is regarded as a neurodevelopmental disorder. It's characterized by persistent inattention and or hyperactivity and impulsivity that interferes with functioning or development. And the key thing is that ADHD starts in childhood. A person is born with ADHD. The symptoms of ADHD need to be evident in more than one setting, for example, home, work. And the symptoms vary depending on the environment and the cognitive demands. So somebody might be in an environment where they're getting lots of support. So a kid might be in primary school, they've got a teacher they really like, the teacher sort of knows it's best to sit Sarah in the front of the class, and so this kid may do well. Another child may be in a class where the teacher, quite frankly, doesn't like that child. They're in the back of the classroom, they're causing problems. So it's quite interesting how important the environment is in terms of how a person's ADHD may play out in terms of childhood, young people and adults. ADHD is a family affair. There is no doubt about it. So adults with ADHD are far more likely to have children with the disorder. And as many as 40 to 50% of their children will have at least traits of the disorder. There have been really extensive epidemiological and genetic studies that have proven this. And clinicians are often asked to assess the spouses or children of adult ADHD patients. That's certainly my experience. The epidemiological studies estimating the prevalence of ADHD are varied, but there's a range, I guess, in children of 4 to 10%. And it's believed that at least 2/3 of children and adolescents continue to have ADHD extending into adulthood. And in the National Comorbidity Survey, it was estimated that around 4.4% of adults had ADHD. So there are quite a lot of people with ADHD, and most of them are untreated. So ADHD is dimensional. So you may have a person who has mild symptoms that may or may not require treatment. The condition evolves over time. Hyperactivity, if it was present in childhood and adolescence, tends to diminish towards the end of adolescence. And in adults, it's really more the inattentive symptoms that are likely to be a problem. tied in with that are the executive functioning impairments. And so this is where adults really run into trouble. And I'll go into that in a little bit more. And this is particularly, as I alluded to before, where scaffolding is removed. So a classic example of that might be a young person is in a school where it's very structured, where they go home and they've got supportive parents and their parents are making sure that their homework's being done. And then they're launched into university and suddenly they're on their own. There's nobody telling them, look, you need to get up, you need to do this, you need to do your homework. And that is where somebody can really fall down if they haven't actually had good treatment and support. So looking at my practice, I have quite a large number of people who present to me who have ADHD. And it was funny how this started. It's now about 15 years ago. I had a child adolescent psychiatrist who just abruptly left his practice. And I don't know why, but he just sent 20 of his young people to me. I knew nothing about ADHD. I had not treated anybody before. And so it was a very steep learning curve where I suddenly began to have to deal with and understand ADHD. And as I started to become more comfortable and understanding of ADHD and treatment, I actually started to really like it. And one of the reasons is that it's actually a condition that's very satisfying to treat. So many of the patients that come to me have a range of problems, and it's often not just ADHD. Comorbidity is important. I've talked about the environment and how that can impact on a person's ADHD, but the factors that really make a difference are how well a person understands ADHD, how well a family understands. So psychoeducation is really important. The severity of the ADHD can really be significant. I think it's also perhaps more problematic too if, say, a mother in a family has severe ADHD, because unfortunately, in general, it's usually the mums who are made to feel that they're responsible for running a household. And so you can imagine if you have a mum who has ADHD that's not being treated, that impacts on the rest of the family. So kids are taken to school late, lunches don't get made, kids are not getting showered and looked after, and that can be a problem. In terms of personality style, this is something that's very interesting too. So sometimes people may actually be quite conscientious and have ADHD. So they keep trying and trying and trying. And other people may not be. They go, oh, that's all right, that'll do. Moving forward with people going through school and later into university or TAFE and other studies, that the right level of support is very important. And what I think is interesting is that in school, in high schools, unfortunately, support for kids who are atypical, like people with ADHD or with autism spectrum, they really don't have much support, which is a shame. There's far more support in TAFEs and in university and in some work environments where the work environment can actually be adjusted to make things better for people with ADHD.
Can I just ask a question there, Hugh? Because I think this is an interesting thing that I think that slide talks to. And that's that notion of if people are referred to an ADHD specialist with a query of ADHD, how much do you and your colleagues work to refute the diagnosis? And that may sound somewhat jaundiced, but I've had the experience of talking to patients and they say, well, you think I've got it and you're sending to somebody who's an expert in it. What's the chance of me coming out without a diagnosis of that? And I say that very respectfully, but I guess you're working towards excluding other things that you'll talk to.
Look, I think it's interesting. And I think that there possibly are people who may not have ADHD. That's possible, who've come to see me. I think that one of the problems for me is that because I am interested, then the number of people sitting in my waiting room is going to be artificially biased anyway. So they probably are going to have ADHD, or it's more likely that they will. In terms of trying to determine do they really have ADHD, one of the things that I find interesting is that in some ways, I think it's easier to really be thorough and diagnose ADHD compared to, say, bipolar 2 disorder, which has gone through a phase where it was almost fashionable, if you like. And that is harder because to make a diagnosis of bipolar 2, you need to have established, has this person had a hypomanic episode? So this is the problem, I guess, in psychiatry, it's subjective. There's no specific test. I would say too that we really do rely on talking to the patient and trusting what the patient says. So it's possible that I could be deceived. I think in general, most people are not doing that. They genuinely want to get help. If somebody doesn't have ADHD, they're not going to get a great response with stimulant medication anyway. So there's this idea, I guess, that all of us could benefit from stimulant treatment. That's true a little bit. But for people with ADHD, it makes a significant change. There's actually a large effect size with stimulant treatment. So I guess the answer is that I think that's possible, that I'm seeing people who may not have it. I think over time too, so what I'm constantly doing, I guess, is reassessing, reevaluating. Well, look, on balance, I think you have ADHD. I think you also have social anxiety. Here's some information. Go and have a read of it. Can I talk to your partner? I think another thing that's really helpful is school reports. And I'll show you that. So that you can actually get this amazing data that looks back. And usually the teacher isn't even thinking about ADHD. They're just commenting on behavior. And it's so characteristic. It can be helpful as well to just, speak to a spouse or speak to a parent to get some of these descriptions. And you get some amazing descriptions of what people are like, making comments about how they talk over people or how they're just chronically disorganized. And so that's very helpful. So I think if anything, in some ways, ADHD may be a little bit easier to be clear about a diagnosis, provided you know what you're looking for. So this is another one. So all psychiatrists assess and treat ADHD.
And actually, we've got a question which is actually very relevant to this, Huey, and this is around how can we get these patients assessed in a timely fashion when the local specialists won't see them? What telehealth options are there, and other options which aren't going to cost the patients thousands of dollars for assessment?
Look, I think it's really frustrating that it's actually not easy in terms of getting assessments. I'm the same. I have a 6-month wait list. Despite working 3.5 days a week, I'm seeing one new patient a week, which in some ways is not great. And one of the things that I'm hoping to try and do is to try and refer more people back to GPs to continue to manage their ADHD once they are just taking the same medication. So I have quite a few people who I've been seeing for years go to see once every 6 months or even once a year and write a script in the middle. So I think there are two parts to it. One is that there are not many psychiatrists who are treating ADHD. That is improving. And also that the psychiatrists who do are still following up and probably should be referring more people back for treatment. It's interesting, I went to a peer review in the Northern Rivers, and it's funny, most of the psychiatrists say, oh my goodness, all my referrals, they're all people coming and saying, the GPs are referred saying they have ADHD, can you please assess and treat? So I think what is also happening is that more psychiatrists are being forced to change their behavior. It's no longer good enough to say, oh, I don't do that, or I don't believe in it, or I don't treat it. And I think also there's a new professionals organisation called ADPA, the Australian Professional Association for ADHD, and that is actually really helping, I think, to improve awareness and get psychiatrists and clinical psychologists and other people involved in understanding about ADHD, and GPs too. I'll show you the link to ADPA. This is a common one too, that often, this is what psychiatrists who are not familiar with ADHD worry about. They're worrying that people with ADHD are really just coming to get drugs. One of the interesting things is that there's now a lot of evidence that treating patients with ADHD decreases substance abuse, which makes sense. If you're impulsive and risk-taking, then if you are treated, you're going to be less likely to take risks. ADHD is very much a serious condition and is underdiagnosed. And I'll just show you, this was a very detailed bit of research that was done by Deloitte, and they worked out that this is in 2019, that over 800,000 Australians are affected by ADHD. It's a lot of people. And that most of those Australians are untreated. It was the most common mental disorder in children and adolescents. This was in 2015. The total financial cost, which is of course what governments are going to be interested in, was enormous. The point about mortality is really interesting. This is a very good study that was done by Dalgaard et al. And published in The Lancet in 2015. And it's looking at people in Denmark, and they had an enormous number of people in this survey. And what was fascinating is that people who were untreated were 2.6 times greater to die, not from anything medical, or there were all the confounding factors were removed, but it was just from accidents. So people with ADHD are more likely to have car accidents. They're more likely to take risks and die. And treatment decreases that risk. So that's a very significant thing. So There's a point at the bottom that people who take stimulant medication have a 40% lower risk of car accidents. So now whenever I treat my patients, one of the first things I say to them is they must take their stimulant medication when they drive. This is just really looking at the data flagged in a graph, and you can see the numbers and how it sort of drops off down the curve towards as people get older.
So there's a question around gender distribution, and also, is the incidence increasing, or just that we're becoming more aware of it and making the diagnosis?
I think, unlike depression, which is increasing, interestingly, I think that ADHD, the prevalence is pretty steady. And I think it really is that we're becoming more aware of it. And I think patients are becoming more aware of it. And they tend to, be quite proactive. They can go online, they can, read a lot of information, they talk to their friends. The prevalence in comparison to males and females, it's interesting, in children and adolescents, it's about 2 to 1, but it's still unclear whether that is actually artificial. So it may be that more girls have more inattentive type of ADHD. So they're quiet and they're not being disruptive and not causing problems. So they're unrecognized. And then as they get more into sort of late teens, early 20s, it starts to become more likely that women will start to be recognized and treated. So it gets closer. It's still not really clear why that is. This is just pointing out that it doesn't matter how bright you are, you can still have ADHD. I'll sometimes hear a patient will say, look, I went and saw this psychiatrist and they said, oh, you can't possibly have ADHD because you're a doctor or you're a lawyer. And the fact is you can. And the thing is that despite being very bright, everything is just more effortful. It's just harder to function and harder to do everything. And for those people who have managed to get through a degree like medicine, that's a real achievement for them. But treatment can just make their lives so much better and so much less stressful. So this is just pointing out some of the clues in the clinical history. When I see somebody, I will tend to sort of go through a bit of a list when I'm fishing around for ADHD. Procrastination is an absolutely ubiquitous experience for people with ADHD. So when somebody says they don't have problems with procrastination, I'm starting to think, oh, maybe they don't have ADHD. People with ADHD just have a lot of trouble getting started on things that they don't really want to do or that are effortful. I've seen many adults who have not done their tax return for 7 years. They will just keep avoiding putting it off. In relation to time management is another thing. There's very good evidence that people with ADHD actually have a problem with estimation of time. So if you get 2 10-year-olds, one with ADHD and one without ADHD, and you get them to cross the road, one kid will look to the right and see the truck coming, and a kid with ADHD will not be as good at estimating, is that truck far away enough for me to cross the road? It makes them more vulnerable to accidents. And it also explains why people are late for appointments, because I've had many patients who they've got ready to come on time, but they say, oh, I'll do some washing or something. They kind of lose a sense of how long it takes. So time is very important. It is very common that people are disorganized and commonly forgetting, misplacing, losing things. So they're constantly losing their keys, their wallet, their phone. People with ADHD are more prone to having driving problems. So they're more likely to have lost their license. They're more prone to road rage. They're more likely to have parking fines, speeding fines, losing their license. That history is really common. I've even had people who've been fined for not paying their parking fines. Sleep is a big problem. 80% of people with ADHD have a delayed sleep phase problem. So they will tend to delay going to bed. And many of my patients say it's boring. It's boring going to bed. There's far more interesting things to do, like on the internet or watching Netflix, and they just do not want to switch off. So it's really hard for people with ADHD to switch off. And of course, as a consequence, then they're really tired, and that makes everything worse. In conversation, it's really common that people with ADHD are prone to blurting things out, interrupting, oversharing. And as a consequence of these symptoms, people with ADHD will often have low self-esteem. They're often told that they're stupid, lazy is a big one, when in fact, they've often been trying much harder than other people to do things, but they just cannot get them done. So somebody with ADHD may not have all these things, but these are the classic kind of clues, if you like, from a history. This is a report from a patient who I saw in his 50s. And it's beautiful. He went to a very nice school. There's the fountain pen. And I've written the comment. So this is when this man was 12 years old. nobody was thinking about ADHD, but here they are saying more concentration required. He tries very hard always. He's often distracted in class. Concentration needed next term. Didn't matter this term. He's anxious to do well, but does not always comprehend quickly. His attention is insufficient. He will change his behavior in the science laboratories, which has been stupid and dangerous. Now, you wouldn't get these politically incorrect kind of reports, would you, these days? But they're so helpful. Here he is, he's 13 a year later. He's not really settled into a working frame of mind. A student with a keen mind. He's not learned that he must be consistent. Always tries hard. There is a pleasing sensitivity about his character. His shirt is too often hanging out. He cannot be a good scholar if he has an untidy outlook. And here he is, 15 years old. He's still inclined to be a little careless, both in his working and organisation. For him, a relatively poor term, he's been distracted far too often into unproductive areas not related to science. I hesitate to use the word lazy. Lack of zest is the problem. I think the view that he is amicable but not very hardworking puts it nicely. That's from the principal. So these reports are just amazing because they're really actually reflecting the symptoms of ADHD absolutely beautifully. And the sort of question about, is this person lazy? I think some of the reports are useless. Like certainly the tick boxes are no good. It's really more about the comments. And you get some great comments in reports. And often what I find fascinating is you might get a fistful of reports, and year after year after year after year, people are commenting, but nobody's done anything about it. It's really incredible. This is a questionnaire that I would encourage you to get your registrars to use and for you to use yourselves. It's a very good screener. It's produced for the World Health Organization. This is about the third iteration of it now, and it's now very brief. And it's just good as a way to screen and to help you decide whether the person has ADHD. So is it common for ADHD to be part of other coexisting psychiatric diagnoses? It's so common. And it's interesting if you think about it too. If you have ADHD and you're a kid at school and you are blurting things out, you're interrupting, you're a nuisance, you could be the class clown and be quite appreciated if you're clever. But very often you may not be. And so you may be excluded, you may be told you're silly or you're not good enough. And so it really can lead to kids with ADHD having terrible problems with anxiety and depression. So just from having their ADHD, but at the same time, comorbidity is common. And so it's very common that people with ADHD may present with depression or anxiety, but their ADHD is not recognized. So the depression and anxiety is treated, but their ADHD isn't. So they don't really do as well as they could. So then the question arises, well, what do you treat first? In terms of deciding that, what you want to be aware of too is comorbidities, not only mental health comorbidities, but potential underlying medical comorbidities. And it's particularly with people having more problems with weight gain. Sleep apnea is a really important one. It's possible for somebody to appear to have ADHD when in fact they've actually got a really severe obstructive sleep apnea. Sometimes, I guess, some of these things may contribute to problems with cognition, and certainly severe substance dependence can really knock people around. And of course, a head injury. And the interesting thing, of course, is that there's some evidence that stimulant medication can be helpful with people who've had a traumatic brain injury. In terms of dealing with comorbidity, when anxiety or depression is comorbid, you treat whatever condition is more severe first. What I tend to do is I tend to ask the patient, look, if we let you start stimulant treatment, it may do this. If somebody was depressed and they're suicidal, then I'm going to treat their depression first, and I would negotiate with the patient. If bipolar disorder is comorbid, that is trickier, and it's very important that they are on a mood stabilizer and that their mood is stabilized. And similarly, with psychotic symptoms, that's really something that you want to be fairly confident about because, of course, stimulant medication is dopaminergic. Most treatments for antipsychotic medication are dopamine blocking. So when substance abuse or dependence is significantly comorbid, that's really important to deal with that first, particularly if they're abusing stimulants like ice or speed.
And a question, what about comorbid autism spectrum disorder?
It's really common. So maybe something like 30% or more of young people with autism may have ADHD. So that it's kind of the genetics, they're overlapped and shared. And so some kids who have ADHD are also on the spectrum and vice versa. And it's important, I guess, to look and see, because it really could help those kids on the autism spectrum to treat their ADHD if they have ADHD. It's interesting. I've really only become more aware and appreciative of people on the autism spectrum really over the last 5 years. And I think that a lot of psychiatrists are pretty ignorant about it, really. There's a great lack of services and support as well for when you start somebody on stimulant medication. What do you think?
Just to comment as well, in treatment refractory depression, we should consider ADHD. A good point for our registrars across the board, really, if we're treating something and they're not responding to what we think should be working, we need to reconsider the diagnosis, both in mental health practice and more broadly.
It's a really good point. And it's true. I think that if you were to take, well, certainly the average psychiatric practice, I'd estimate probably 30% of patients in the waiting room may have ADHD. And it's because of the comorbidity that it really increases that likelihood of the apparently refractory or non-responsive depression. It may be because there is an underlying comorbidity of ADHD. It's really pretty easy to screen and then to pick up and explore a bit more to get more evidence. Is it relevant? So when people respond well to stimulant medication, they will generally say they feel calm. And it's often quite a surprise because of the name stimulant, people think they're going to be stimulated. However, having said that, sometimes people do find that they're more aware of their heart rate because the stimulant medication does generally increase heart rate a bit and increases blood pressure a bit. And in some people, they're more sensitive to that and it can make them feel anxious. But when somebody responds well, they tend to feel calmer. And it's probably because suddenly things are just easier. It's just easier to start things, easier to stay on task, not get distracted, start things, stay on task, complete them. And suddenly they're not anxious because often they've been putting things off. And suddenly things are getting done, things are being completed. And so it's a tremendous relief and an incredibly gratifying condition to treat because the response rate is generally high. 90% of people with ADHD will respond to one or other stimulant, dexamphetamine or Ritalin. So that means 10% of people won't, but there are now good non-stimulant treatments available too. Can GPs prescribe stimulant medication? So yes, it's true. And the thing that's a little bit frustrating is that every state and territory has different rules. One of the things that ADPA, the Australian Professionals Association for ADHD, is really hoping to do is to try and make the rules more consistent across states. And there's a link, I think, in the teaching sheet for ADPA, which you can look at each state and find out what are the requirements. So in New South Wales, where I work, I'm able to hand referral back to a GP indefinitely. And we'll have a look at that. These are the standard treatments that are available. I won't go into them, but this is from the NICE guidelines. This is from the New South Wales State Health Department for their forms that you use to prescribe stimulant medication. And the form that GPs use is the same as the one I use when I'm wanting to prescribe higher doses of medication for people than I'm allowed to prescribe routinely. So the form must have a letter. So I write a letter. And one of the things that is confusing is if you see down below where number 14, if you're a specialist, go to question 15. If you're not a specialist, indicate the circumstances. So what I'd be doing is getting the GP to tick the treating specialist has requested I continue prescribing for this patient to be reviewed annually. I've had many GPs who've sent the patient back after a year to say, oh, you need to come back to you to be reviewed. And it's annual reviews with the GP. So the form or the application for the authority number needs to be done annually. And I guess this requires a bit of organisation for the patient and the GP to book those appointments in so that the patient doesn't run out of their medication. And of course, the pharmaceutical regulatory unit is not terribly quick in processing the form. So it often takes 10 days to 2 weeks for them to do it. But I think it makes a lot of sense when people are stable and taking medication for GPs to continue prescribing.
With you presenting on this topic, informing GPs about this condition and hopefully diagnosing the need to manage it more with an increased awareness in the population, there's really no way you're seeing one new patient a week with a 6-month waiting period. Is there scope for general practice to embrace this condition, be initial prescribers of stimulant medication? Is that being discussed?
Look, it is. And there are actually some GPs who do. So the answer is yes. And I think that that would make a lot of sense, that happens more.
In the theme of this being supervisors supporting registrars, I mean, obviously we know that supervisors will be upskilled in these types of clinical areas, but it may be a stretch for a registrar to embrace this really fully. But I think you've presented on the need to absolutely know what some of the medical legal requirements are when they're faced with patients that may be requesting stimulant prescriptions. But we certainly have a fairly broad group of registrars that come through, and they may be very passionate about this and keen to upskill. So I guess there is scope in terms of training and engagement.
And it certainly would help. That's just more looking at the form. So just pulling this together, what I'd really like people to be aware of is just how stigmatizing ADHD is for people. And it's even when you ring up and get an authority, and you can sometimes feel on the end of the phone, can that person really have ADHD? Why are you treating this adult? So it's something I hope that will change over time as people become more understanding. And there is no doubt about it that ADHD is undertreated, not overtreated. There may be some parts of the United States where it is overtreated, but that hasn't happened here yet. Remember that ADHD is a family affair. So it's so common that if a child has ADHD, it's very likely one of the parents do. It's important to think about ADHD with and without comorbidities. Use the screening questionnaire. I think that's really useful. And having that, I hope that registrars may be able to feel comfortable about co-prescribing. And if you're interested in knowing more about ADHD, get involved in ADPA and join. It's a blossoming and growing organisation, and it's a multidisciplinary group. It has GPs, psychiatrists, psychologists, ADHD coaches. It's good. And just to conclude, I really enjoy treating people with ADHD. I'm learning all the time. I love how people respond so well. The effect size is large. There are very, very few treatments where you have an effect size of 0.8 to 1. I love the variety of presentations. I love the fact that there's comorbidity. It just makes it more interesting. And I just really hope that registrars, psychiatrists, GPs, pediatricians, clinpsychs, allied mental health clinicians will regard ADHD as a common and readily diagnosable and treatable condition, and that we should be assiduous with our clinical care. And I'll just move on to questions and discussion.
A couple of comments from Victoria. The department's policy is that specialist involvement is necessary for the diagnosis and ongoing management of all ADHD patients. A reminder that Hugh has written a new teaching plan on ADHD, which it's already been published on the website, so you can avail yourself of that if you're keen to have a look at that and teach your registrars about this tomorrow. How's sleep impacted by stimulant medication?
Sometimes sleep is improved with stimulant medication. So it's quite interesting. People may find once they're more organized and active and productive during the day, that they often feel they can wind down and get into a better routine. Some people, though, find, particularly with long-acting stimulants, that it does actually keep them awake. In general, 80% of people have problems with sleep. So I'm using melatonin a lot. And I get people to get it online. It's cheaper. And I will generally prescribe 3 milligrams to 6 milligrams of melatonin. Some people may not respond to that. And I would use clonidine catapress, 100 micrograms to 200 micrograms commonly to help. Sometimes, interestingly, people with ADHD may actually take a small dose of short-acting dexamphetamine or Ritalin, and it helps quieten their mind, and they feel better able to go off to sleep. So it's very much individualizing their treatment. But yes, stimulants can sometimes disrupt sleep. It's true.
I have a few families with multiple children with combinations of ADHD, autism, and other mental health conditions like depression and bipolar, all associated economically disadvantaged. Is there a social issue in the epidemiology?
I'm finding, working in the Aboriginal Medical Service at Lismore, I feel like every second patient I see has ADHD. Why? Because they've got horrible trauma histories. Some of them have fetal alcohol syndrome. They may actually have head trauma. So all these things may increase the likelihood of ADHD. So the answer is yes, there may be an increased preponderance of people with learning disorders, with ADHD, with ASD. Yes.
Acquired brain injury and the benefit of stimulant medication. One of the GPs was very interested to know what experience you might have had in that. Patient comes to mind with poor concentration, forgetfulness, and how that might be explored, I guess.
Stimulant medication has been used for years to help people with brain injuries. And there are two things. It may help improve concentration. It's sort of like potentially a model for ADHD. So they've had a brain injury, and that has impacted on focus and concentration. It can also be helpful for helping with mental alertness, because a lot of people with a traumatic brain injury experience this kind of fog and fatigue. So I've certainly had some people who do benefit. With that form, you could potentially apply to trial stimulant medication. And if that person with their head injury, if there are other people involved to support that, that could be helpful. But yes, it's certainly worth trying. The other medication, but it's expensive, is modafinil. So that's another one. But methylphenidate is cheap. So it could be helpful.
And what's the role of psychology, more specifically in the question CBT, in management?
So the first line treatment of people who have moderate to severe ADHD is medication, generally stimulant medication, if that person's suitable. Once somebody has responded well to the treatment, two things. One is that they really still may need help to manage their ADHD. So one option is to engage an ADHD coach. And there are more ADHD coaches now, which is good. Also, comorbidity may be there. So they may have comorbid depression, anxiety, self-esteem issues, substance problems, and they may need CBT. Generally, I guess many of the patients that I'm seeing would be seeing either a psychologist or a coach. Sometimes, a bit like, when you treat depression, somebody responds really well to the antidepressant. They say, thanks very much, I feel a lot better, see you later. But I guess with depression too, that often people find, oh, look, I'm better, but I'm still worrying. And so often best treatment is going to be both psychological and medication.
The question here about the inattention in autism spectrum, Asperger's, and a role of stimulant medication there. And I guess maybe the question is not in a comorbid presentation, but specifically in the absence of ADHD. Is there a role?
I think that because there's such a genetic overlay, and it depends, I guess, on how severe the person's autism is, then it's really interesting. Sometimes if you tease apart, well, what's going on? Why is this person having difficulty focusing and concentrating? And so I've had young people, for example, saying, this guy keeps tapping his pen and I just can't concentrate. So sometimes they're so hypersensitive to noise, or it's more about what's happening in the environment. So it might be that wearing something to sort of help stop being distressed by the sound could be there. I think that if there was generally problems with focusing, concentrating, it still might be worth trying stimulant medication.
I think it's fair to say you've pitched the session tonight at adolescents and adults with ADHD. You're not a child psychiatrist. A question and a comment around children. As GPs, children, should we be sending these children off for sort of neurodevelopmental assessment, comprehensive assessment in that regard, where I guess the diagnosis may be a little harder? And in a comment, you talked about the fact that your understanding is that there hasn't been an overprescription of stimulant medication. And again, I'm not sure whether you're talking about in adolescents and adults. If you're happy to talk to management of children and whether actually overprescription is more of a concern in children.
In terms of getting children assessed, I think if you were, say, advising parents, I would be getting the parents to talk to the teacher, to possibly look at having an educational assessment. And that could be with an OT or a psychologist who specializes in those assessments. And there's some evidence that it may be worth just trying behavioral strategies first, but it depends on the severity. And the people who are going to be more easily accessible in New South Wales anyway are pediatricians. And so there are quite a few good pediatricians who are interested in assessing kids. So that's what I would do. In regards to overprescription, there really is no evidence that it's being, at this point, overprescribed. There's definitely enormous variation in prescribing and access to pediatricians and psychiatrists. And so certainly in well-resourced areas in Sydney and in Melbourne, people have more access. But as far as I'm aware, in Australia at the moment, no, even though the rates have been increased. If you look at the overall numbers and the estimates of how many children have ADHD, which I think children and adolescents may be 500,000, the percentage who are actually being treated is low.
I would flag the fact that it's about supporting registrars. Again, knowing that you as clinicians will take a lot of this away and practice it, and your knowledge and skills can then permeate down to your registrars. But more specifically, have a look at the teaching plan, which we put together just prior to this webinar. the usual format of key areas, good resources, some of the ones that Hugh's mentioned, this screening tool. And there's also a clinical reasoning challenge, which is really a role play. And again, I push role play so hard with in-practice teaching, supervisor, registrar education. And so you may not be an expert in this area, but what we've done is taken some of those key historical aspects that Hugh mentioned, and indeed are reflected very well in an article he published in Medicine Today. And really just, even if you don't feel hugely confident about this area, maybe just role play a patient who's presenting with a non-specific issue and how well a registrar can start to interrogate and tease out some of those things. So thank you very much. Look forward to seeing you all at an upcoming webinar, and we'll see you very soon. So thanks so much.
Thank you.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervisors Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.